The major obstructive lung diseases are asthma and COPD, which has two major presentations, either chronic bronchitis or emphysema. In all three of these disorders, when airway resistance increases due to chronic changes or acute exacerbation, pulmonary function is compromised. Airway resistance is partially determined by the contractile state of the bronchial smooth muscle. The sequence of events leading to bronchial smooth muscle contraction consists of intracellular calcium accumulation, calcium calmodulin binding, phosphorylation of myosin light chain kinase, and actin-myosin cross-bridge formation, shortening the cells. Because the airway's smooth muscle cells are arranged radially around the airway walls, smooth muscle contraction leads to airway narrowing. Activation of the enzyme myosin light chain phosphatase or inhibition of the MLCK produces smooth muscle relaxation and increasing airway diameter or bronchodilation. Exercise or the fight or flight response increases the sympathetic tone to the airway, promoting bronchodilation. The pleural space is a virtual space lying between the parietal pleura, lining the chest cavity, and the visceral pleura, or the membrane covering the lungs. At functional residual capacity, these two forces are balanced, tugging with equal strength in opposite directions. The negative pressure acts like a vacuum, pulling together the surfaces of the parietal and visceral pleural membranes with the stiffer structures of the chest wall lining the delicate lungs open. The pulmonary function test is provided to anyone that is having lung-based disease processes or issues. Tidal volume is the volume of air inspired and expired during quiet breathing at rest when multiplied by the respiratory rate or breaths per minute. Then the resting minute ventilation is calculated. The functional residual capacity is the volume of air in the lungs at the end of each expiration at rest. This represents the resting position of the respiratory system, which is the lungs plus the chest wall. At this point, there is an equilibrium between the intrinsic tendency of the lungs to collapse down and the intrinsic tendency of the chest wall to expand outward. Functional residual capacity is sensitive to disease processes that can alter the lung or the chest wall mechanical properties. Vital capacity is the maximum volume of air that can be exhaled after a maximal inhalation. Depending on the context, this value can also be called the forced vital capacity. This represents the greatest volume of air the respiratory system can move in response to the maximal expiratory effort. Vital capacity is sensitive to disease processes that affect the lungs, the chest wall, and the neural control of the muscles of respiration. Residual volume is the amount of air in the lungs after a maximal expiratory effort. The residual volume depends on the elastic recoil of the lung, and it is altered by diseases that affect either lung or chest wall compliance. It is measured by helium dilution. Total lung capacity is the amount of air in the lungs after a maximal inhalation. It is also equal to the vital capacity toward the residual plus the residual volume. The total lung capacity is similarly affected by chest and lung disorders, as well as neuromuscular disorders that affect the muscles of respiration. Functional residual capacity is the amount of air that is left after expiration. A spontaneous pneumothorax occurs and air accumulates in the pleural space, allowing the lung to collapse. The pleural space contains a small amount of pleural fluid that keeps the tissues lubricated and reduces the friction between the chest wall and the lungs. In this image, the volume of air inside the lungs at end expiration is determined by two factors: the elastic recoil tendency of the lung to collapse down, and the tendency of the chest wall structures to expand outward. The balance between these tendencies creates a negative pressure in the pleural space that holds the visceral and parietal pleura together. If a pneumothorax occurs, air then enters the pleural space, and the pleural space now has pressure of the atmosphere inside. Immediately, the lung will collapse down and the chest wall will expand. The image here depicts lung pressures and the volumes at the beginning and the end of quiet inspiration. At the end of a normal expiration, the lung volume is functional residual capacity. The diaphragm and the external intercostals are relaxed, and the pleural pressure is -5 centimeters of water. Therefore, the distending pressure holds the lungs open. The distending pressure holding the lungs open is the pressure inside the lungs minus the pressure outside the lungs, or a +5 centimeters of water. At the end of normal inspiration, the external muscles are contracted, pulling the chest upward and outward, and the diaphragm is contracted, descending and lengthening the thoracic cavity between the neck and the abdomen. The volume is then increased to the functional residual pressure plus the tidal volume, and the distending pressure on the lung has increased to 8 centimeters of water. The relationship between the volume change of the lung with the distending pressure is termed the compliance of the lung. From functional residual capacity, it takes 3 centimeters of water pressure to inflate the lungs with the usual tidal volume. The response to physiologic needs during exercise, the inspiratory muscles are able to create a more negative intrapleural pressure and drive the intake of a greater inspired volume. Diseases of decreased lung compliance create a stiffer structure, thus greater pressure changes are needed to maintain even normal tidal volume. As a compensatory measure in certain conditions, there is an increase in respiratory rate and a decreased tidal volume, creating more work for the individual, especially when there is dead space ventilation. But it does reduce stress on the inspiratory muscles. Diseases of increased lung compliance, like emphysema, make it easier to inflate the lungs on inspiration, but also result in a much higher functional residual capacity than that can limit the maximum inspired volume. The inverse of compliance is elastance, which is the ability to recoil and return to their original size after being stretched. The lung's elastic recoil and conversion of stored energy generates pressure that drives expiration. Therefore, diseases that alter lung compliance will also alter elastic recoil. Surfactant, or the fluid that lines the alveoli, is a major factor in lung compliance. Surfactant greatly reduces surface tension, making inspiration easier. It also reduces alveoli surface tension. Type 1 AECs are the thin cells making up the majority of the alveolar wall. The interface between alveolar air and tissue fluid lining the alveolar wall is the source of potential surface tension that would oppose alveolar expansion during inspiration, decreasing the compliance. The type 2 AECs synthesize and secrete surfactant, which is a fluid rich in amphipathic phospholipid molecules that spread out on the top of the fluid facing the alveolar air, greatly reducing surface tension and making alveolar expansion easier. These are mechanisms that help to protect the lung to maintain its normal elasticity. Emphysema is a disease of increased compliance and decreased lung elastic recoil due to an imbalance of forces that damage the structural fibers of the lung and the forces that protect against such damage. Proteases break down extracellular matrix, and local inflammation perpetuates neutrophil recruitment and induces alveolar epithelial cell apoptosis. Emphysema is characterized as an obstructive disorder and overlaps with chronic bronchitis. Therefore, further complexity arises when patients have a combination of emphysematous changes or an enlargement of air spaces and a thinning of extracellular matrix with fibrotic changes that are due to chronic inflammation. Major genetic disorder that increases emphysema risk is alpha-1 antitrypsin deficiency. The elastic recoil of normal alveoli is lost in emphysema. With normal alveoli, the elastin fibers in the walls create elastic recoil upon expansion that is due to inspiration. Relaxing the diaphragm and external intercostal muscles promotes passive expiration that is proportional to the degree of lung elastic recoil. With emphysema, the elastic recoil decreases when elastin fibers are destroyed by the disease process. There is little elastic recoil, and air remains trapped in ever larger spaces within the lung. Lung stiffness increases acutely during cases of pneumonia or acute respiratory distress syndrome, and chronically in many diseases of lung injury, inflammation, and connective tissue accumulation that may affect the lung interstitial tissues. These are termed as restrictive lung disorder due to the amount of restriction on the lung expansion. Interstitial lung disease is a term that encompasses many of these various conditions that include idiopathic pulmonary fibrosis, sarcoidosis, systemic lupus erythematosus, rheumatoid arthritis, and scleroderma. Various changes to chest wall properties can also alter compliance of the lung-chest wall unit, resulting in compromised ventilation. Musculoskeletal conditions, kyphosis and scoliosis, can impinge on the volume of the thoracic cavity. Surgery and trauma to the chest wall can reduce mobility, and obesity can decrease the thoracic volume. The airway resistance is inversely proportional to the fourth power of the tube's radius, meaning the smaller the tube, the greater the resistance. The greatest degree of resistance is encountered in the upper airways, noting generations 1 to 8. Beyond generation 8, total cross-sectional area increases and resistance decreases rapidly. At the total lung capacity, resistance is lowest, while expiration is associated with progressive increases in airway. At total lung capacity, resistance is lowest, while expiration is associated with progressive increases in airway resistance that reaches a maximum at the residual volume. During pulmonary function testing, the individual's ability to deeply inspire and then forcefully expire a maximal breath is measured. The volume of air in liters inspired and then expired is measured, and the rate of airflow in liters per minute is determined. One data display will show the volume expired during the time of the forced expiration, which is volume of time analysis, and the other plots the rate of airflow during expiration relative to the volume of the air remaining in the lungs. Here is a plot of the volume of air expired over time during spirometry. The forced expiratory volume in 1 second represents the volume of air expired in the first second of a forced expiratory maneuver. This corresponds to the time of minimal airway resistance as the maneuver begins at total lung capacity. Forced expiratory volume is generally 75 to 85% of the forced vital capacity. This image depicts spirometry flow volume analysis. Airflow, shown with directional arrows, is depicted during a maximal inspiration and a forced expiration from total lung capacity to residual volume. The small circle shows the usual flow volume relationship during a normal quiet breath from a volume of functional residual capacity to a functional residual capacity plus tidal volume. The inspiration is associated with increasing flow rate to a maximum, a plateau region at that maximum, and then decreasing the flow rate until total lung capacity is reached. Forced expiration is associated with an early increase to peak expiratory flow and progressively diminishing flow until residual volume remains in the lung. The mechanism is termed as dynamic airway compression. During a forced expiration, the abdominal muscles contract, pushing the diaphragm up and compressing the chest cavity from the bottom. The internal intercostal muscles contract, drawing the chest wall down and in. The pressure becomes positive. The airways are now subjected to greater pressure on the outside than on the inside, giving a negative pressure gradient that tends to collapse the airways. Obstructive airway pathology in asthma or COPD limits the rate of expiratory flow and promotes air trapping, increasing residual volume and decreasing the functional volume capacity. COPD produces marked changes in the flow volume loop with a reduced peak flow, an increased residual volume, and total lung capacity due to trapping air and a concave scooped out appearance of the expiratory flow decline from the peak. The concave flow pattern indicates premature airway closure during forced expiration. Bronchial smooth muscle contraction is under three major influences. Under normal conditions, there is a modest bronchoconstriction due to acetylcholine that is released from vagal innervation of the airways, acting on the bronchial smooth muscle cell muscarinic receptors. During either exercise or stress, circulating epinephrine binds to beta-2 adrenergic receptors that cause bronchodilation. In an acute asthma attack, mast cell-generated leukotriene receptors bind to leukotriene receptors and cause bronchoconstriction. The actions of acetylcholine and leukotriene increase intracellular diaglycerol, inositol triphosphate, and calcium. The calcium calmodulin system phosphorylates the myosin light chain kinase, producing the smooth muscle contraction. The action of the epinephrine converts ATP to cAMP and activates the pKa. The pKa then activates the MP and inhibits the MLCK, which will produce a bronchodilation. These receptor-mediated actions are the targets of many drugs that are used to manage both asthma and chronic obstructive pulmonary disease. Asthma is an obstructive airway disease characterized by acute exacerbations with dyspnea, coughing, wheezing, and airflow obstruction measured by spirometry. The attacks often begin in childhood, during which the most common pathogenesis is a type 1 hypersensitivity or an allergy. Hallmarks of allergic disorders include elevated production of T helper 2 generated cytokines, class switching by B cells that produce IgE rather than IgG, binding of IgE to mast cells, therefore priming them to respond to the allergen exposure by degranulation, releasing histamine and inflammatory prostaglandins. The recruitment of eosinophils to the affected tissue, perpetuating inflammatory mediator production and releasing eosinophil major basic protein, which will further inflame the tissue. All forms of asthma have chronic changes to the airway, including the bronchial smooth muscle hypertrophy and hyperresponsiveness, altered goblet cell function with mucus hypersecretion, and airway narrowing due to fibroblast accumulation. The pathophysiology of asthma is characterized by acute but reversible airway obstruction. In response to allergic and other triggers, the mucus secretion will increase. The mucosa becomes swollen with inflammatory cells and mediators that cause vasodilation and increased capillary permeability. Then the bronchial smooth muscle contracts. All three of these factors contribute to a severely constricted airway and limit the airflow. Airway changes persist with a modest degree of airway narrowing between acute attacks. These changes in the airway will include white blood cell infiltration, particularly eosinophils and lymphocytes, bronchial smooth muscle hypertrophy, hyperplasia, and hyperreactivity. Globally, COPD is the fourth leading cause of death. It is defined by reduced expiratory airflow that is not reversible with exertional dyspnea, cough, and sputum production. COPD is a complex disorder with overlapping disease process that include airspace enlargement due to tissue destruction or emphysema and chronic inflammation with cough and sputum production or chronic bronchitis. Expiratory airflow limitation in patients with emphysema is due to decreased elastic recoil and occurs simultaneously with the increase in lung compliance. Remember that elastance or elastic recoil is the inverse of compliance. Pursed lip breathing may help to reduce airway collapse and support expiratory flow. Exhaling through pursed lips creates positive pressure in the mouth and along the airways, maintaining a pressure gradient that holds the airways open and counteracts the tendency of floppy airways to collapse. The diagnosis of COPD is based on clinical history of persistent productive cough for at least 3 months that is documented in at least 2 consecutive years. Chronic inflammation with neutrophil and macrophage infiltration is similar to emphysema. Increased mucus production, airway mucosal tissue becomes edematous, contributing to airway narrowing, dyspnea, and cough. The chest anterior-posterior dimension may be visibly increased and identifiable on a chest X-ray. Progression is associated with the development of hypoxia and hypercapnia. Respiratory infections are the most common cause of exacerbations in COPD, and vaccinations for pneumococcal pneumonia and influenza are highly encouraged. The management for COPD is similar to that for asthma, which includes inhaled corticosteroids and long-acting beta-adrenergic agonists. Obstructive sleep apnea is the most common example of sleep disorder breathing, which is a condition of abnormal breathing patterns that occur during sleep. The upper airway becomes partly or completely obstructed for 20 to 40 second episodes during sleep. This causes apnea or hypopnea. Both of these cause blood oxygen levels to decline and carbon dioxide levels to rise, terminating in unconscious and unsuccessful respiratory efforts. A brief arousal and surge of sympathetic nervous system activity will occur before sleep resumes. The diagnosis for obstructive sleep apnea depends on sleep lab documentation of the apnea-hypopnea index of greater than 5 episodes per hour, in conjunction with the signs and symptoms of sleep loss, or the AHI, apnea-hypopnea index, greater than 15. The prevalence of OSA, or obstructive sleep apnea, is higher in men and does increase with age. There are findings that will help confirm obstructive sleep apnea. Patients often complain of sleepiness, fatigue, or insomnia symptoms. The patient wakes experiencing breath holding, gasping, or choking. Their bed partner will report snoring, grunting, or snorting, or breathing interruptions during sleep. The patient has a diagnosis of hypertension, mood disorder, cognitive dysfunction, coronary heart disease, stroke, heart failure, AFib, or type 2 diabetes.